All right, yay, it's working. Is everybody awake enough? Old lady. Somebody has their name as old lady. All right, looks like we, number-wise, we're almost to the number that we have everybody on Zoom. Give it just a minute if there's anybody else join in. Let's see, 4, 8, 7, 3, 3, 1.
I think Eddie's just going to be a minute.
Sorry, I couldn't hear you because of the music on the Kahoot. Let me turn the music on the Kahoot down. What was that?
I think just running. Okay.
Thanks, Crystal.
Is everybody good? All right, let's see how it goes. All right, so this one, a patient started on levothyroxine for a new diagnosis of hypothyroidism. Let me move this. Which effects should the patient experience? So does everybody understand why the increased energy now that you see the answers?
Yes.
Okay. Woohoo!
Mine says I'm logged in, but it's not even letting me see the questions on the actual thing.
Is it letting you put in the answers?
No, it's only showing blank, like the blank squares, but that's it. And then it says time's up.
Is it letting you see like the colors, like the red, blue, yellow?
Is it showing it on Zoom? You got to watch Zoom and then your phone.
Yeah, I have it on the screen. All right, so which assessment finding would you report in a patient post-thyroidectomy? So remember the tingling fingertips, what is that a sign of?
Low calcium.
Correct. Very good. So they're gonna, so just to recap, so they're gonna have some, they probably will have a sore throat and some neck discomfort. So it's not that those are unexpected. They probably will have some of these. but I expect the neck discomfort and sore throat, I expect them to have a certain level of that. The tingling fingertips would be the indicator for the low calcium. And if they had stridor, or if this said like severe, if it started to say respiratory distress, then that's when I would use that one as well. Very good. All right, next question. So what would you teach a patient with post-thyroidectomy? All right, very good. So in this, so after the thyroid surgery, odds are then they're going to have hypothyroidism. So then they're going to need some replacement. Next question. Which of the following must you assess in hyperthyroid risk for thyrotoxic crisis or thyroid storm? Very good. So this one it's gonna be your blood pressure and your temperature. Those are your key indicators that you're looking at. So in your vital signs. Keeps changing. All right, next question. Which statement by a patient with hypothyroidism indicates an effective plan of care? Very good. So that energy level, hopefully that energy level is starting to return with the proper medications and treatments. Ooh, 2 in a row for Brandy. All right, next question. So this is, how do you know a patient needs additional education with type 1 diabetes? If they make which statement? All right, very good. So what type of medication is your type 1 diabetic going to be on?
Insulin.
Insulin, and it will not be in pill form. It will be the injectable. Very good. Oh, it's shifting around again. All right, next question. A nursing home patient with diabetes is requesting a heating pad for her cold feet. What is the best response? Very good. So let's see. So some put, let's elevate your feet to promote circulation. Think about that statement for a minute. If you're elevating them, you're actually going to decrease circulation. So yes, your correct answer would be a heating pad can cause burns. So we could try some extra socks. You wouldn't want to do a heating pad or the warm, or putting them in hot, warmish to hot water. If that way, if their sensation is not there, you don't know what they're able to feel at that point. Oh, Brandy's back in the lead. I think there's 1 or 2 more questions. Next one. Which statement by a patient with diabetes ensures understanding to prevent complications? And this one, I thought you could select all, but actually you can't. So just pick one that's correct. Oh, yeah, I could do all. I didn't think I could. So in order to prevent complications, so I want to clarify, so yes, they would do an annual eye exam. They certainly, their goal is to keep their blood sugar under 130 before eating, and then they'll check their feet. So I just want to clarify this statement. I will avoid all sweets and simple sugars. So there may be times where your patient needs some of those short term to get that blood sugar up, but in order to help prevent complications in long term, like they wouldn't want to do the sweets and simple sugars long term. So they want to manage these others to help prevent complications. So just thinking of preventing complications in that sense. All right, Brandy's still up there. All right, this is the last question. For which blood glucose result should the patient take a simple sugar? Very good. So that low one, the 48, they want to get some sugar in and get that up a little bit. I'm glad nobody picked the 223. That makes me feel good. Yay. All right, so with that, let me flip back over here for just a minute. I'll stop sharing my screen for just a minute. All right, any questions so far with diabetes or with thyroid? All right, so if no questions so far, so the plan today, we'll do the presentation on obesity. That's the shorter presentation of the three. And then after that, I can kind of do a little review and then answer any questions. Does that sound good to everybody? Y'all are quiet this morning.
Sounds good.
All right, I'm going to try to record again. We'll see how it goes. All right, so today will be about obesity. So this just shows kind of the graph for the different classifications: underweight, kind of the healthy, overweight, and then obese. This was the latest kind of prevalence that I could find about areas with higher incidence of obesity. Just an interesting little tidbit. So the pathophysiology for obesity. So there are times where there are chemicals and hormones that impact the appetite, your metabolism, and so that can cause then patients to be overweight or even thin, depending on, so just like we talked about thyroid, hypo and hyperthyroid. So that impacts your metabolism. So if you have hyper or hypothyroidism, then that's going to increase the speed at which you metabolize your foods. So there are situations that like that, but then there's also the hormones. These hormones that we're going to talk about with weight control is the and I cannot pronounce it, but the adipokines. So these are the hormones that we're going to kind of focus on a little bit. And so of these hormones, you have kind of two types, the orexins and anorexins. So think of the think of anorexia, decreased appetite, and the I think of overweight, and this stimulates appetite. And so your orexins stimulate your appetite, and then you can cause obesity, and then your anorexins decrease your appetite. I think of anorexia with that, and thinner. So these are some examples of the hormones for your orexins and arexins too. So this just goes into a little more detail of the different types of hormones and exactly what they do, where they act, so that when you hear the different, like leptin, resistin, so when you hear these different hormones, then you know what they're talking about. And then the anti-inflammatory, the cytokines. And so you hear the cytokines being released with different inflammatory responses. I'm going to go back a slide. Oh, whoops, sorry. There we go. For obesity, I'm going to focus more high level. So like your ANA and your orexins, you want to know the different types just because you want to be able to recognize these names as well. And then these are some more that can impact that. So insulin, for example, decreases appetite. So I would want to know, I would want to recognize these names. I don't think you have to know exactly the degree, but you may want to know if they're the orexin or anorexin. Are they going to stimulate or are they going to decrease the appetite? So there's a lot of complications for diabetes. I'm reading diabetes right here. There's a lot of complications for obesity. So in that being diabetes, stroke, hypertension, gout, peripheral artery disease, sleep apnea, all of these. So there's tons of complications that can occur from obesity throughout. So if you have anytime that you have any of those complications because of obesity, it's gone on for a long period of time, then you start to have some of those, once it goes on for a long period of time, then you have some of those adverse consequences. Those can increase. So complications from hypertension, complications from diabetes. And then if you have a patient that's morbidly obese, the definition of that is 100 times their ideal body weight. So if ideal body weight is 100 and they're 200 pounds, that's 100 times their ideal body weight. Those patients are at risk of dying. Their risk for dying is 12 times greater than if it were to be lower. So this certainly impacts their risk factors for other diseases. For a lot of them have metabolic syndrome. It can impact their reproductive functions. So it starts to impact a lot of the various organ systems. So there can be environmental factors, genetic factors. So maybe they were born with hypothyroidism, and so they can have genetic factors. There's also genetic diseases such as The first one that comes to my mind is Prader-Willi. If you haven't heard of that, it's a genetic disorder, and the kids that have it, they eat, like they just can't satisfy, they can't eat enough. And so they're generally overweight. They start off getting overweight and can get to be obese, depending on how that's managed. So there are going to be behavioral factors, diet, and activity. And then there can be certain medications that can cause obesity as well. So I couldn't find more recent numbers published, but 2015 and 16, it was estimated about 40% of the US adults were identified as obese. And then this just gave a breakdown of kind of ethnicities. The biggest thing for me is that the obesity-related conditions, including heart disease, stroke, type 2 diabetes, and certain types of cancer, are the leading causes of preventable premature death. So there's a lot of complications that can occur from obesity. So when you have a patient that is obese, making sure that you have that full assessment, looking at all the body systems. And so in that, get a good history of what's going on. Are they is it an underweight patient? Usually not likely, but is it an underweight patient who maybe has a poor economic status, and is not, just can't afford, can't get in enough? Or is it an overweight patient and also their economic status, maybe all they can afford at the grocery store are the foods that are really bad for you? And so that's causing more of a problem. So backgrounds, their physical assessment, their ideal body weight and their body mass index, body measurements, and then psychosocial assessment. What's their attitude toward food? Do they want to lose weight? Are they motivated? Are they not? Is there some other psychosocial areas going on that are impacting that? So technically, yes, you can technically diagnose obesity. And so in order to do that, they do it in different categories: overweight, obese, and morbid obese. And so this slide is a great slide to know. So your ideal body weight, if it's above up to 10% above your ideal body weight, is considered overweight. Up to 20% is obese, and then once you get up to that 100% or more above ideal body weight, then that's the morbid obese. And then the body mass index gives a breakdown as well for normal, overweight, obese, and morbid obese. So basically your 20, just up to just under 25 is normal, 25 to just under 30 is overweight, your 30 up to just under 40 and then is obese, and then your 40 and greater is the morbid obese. So in that, you'll also want to check a weight or a waist circumference. Oftentimes these patients will have the metabolic syndrome, and that's where the waist ends up being kind of large at the bottom of the abdomen, or larger in that area. And then additional testing. So they'll want to do some additional labs just to kind of check all the body systems and see where the body systems are at. So this would be your either your patient that hasn't been in for a while, or kind of newer to the diagnosis of being obese. So you want to see where their body systems are. So planning and implementation. So of course, diet and exercise. So low calorie, nutritionally balanced diet. You want to start, the main goal with exercise would be 30 to 40 minutes, 5 days a week. That would be the ultimate goal. But if you have a patient that can't start there, then you start where they can and then try to work them up to this. So this being like your ultimate goal, 30 to 40 minutes a day, 5 days a week to try to get that under control. Then there's different drug therapies. So there's the lipase inhibitors, there's the anorexiants, so appetite suppressants. So you can use these drug therapies to help manage that. And then behavioral management, support groups, counseling to help. So there are surgical options as well. So liposuction, I've not heard much in the way of liposuction lately because there's so many other procedures going on. I'm not saying it's not being done. I just haven't heard a lot of discussion about that. Then there's the bariatric surgeries, the gastric restrictive or gastric banding, the gastric bypass, and sometimes they'll do a combination of both. So your gastric restriction procedure is where they're putting that band on it to try decreasing the amount that's going in. So you end up with a small stomach pouch up here. So it kind of decreases the amount the stomach can handle. Then your gastric bypass or malabsorption, so you can see where they cut and move things to make it smaller. So you're bypassing a portion of it. And then it's called a malabsorption surgery. And so just from that word, you can kind of think of potential complications. Complications being they won't absorb all of the nutrients later is a potential complication there. So usually post-op, they're in the, some of this may be a little old information. I think most of this still applies though. I'll tell you, so let's see, post-op, they're usually in the hospital a day or two, depending on that surgical approach that's used. So certainly you're gonna monitor airway, pain management. The part that you may see some differences with is some, and I think it may be surgeon preference, and as they have more research that comes out, some are starting to change their practice. Some will come out with an NG tube and some will not. And so that practice is starting to change just a little bit. So if you do have a patient with an NG tube after one of these surgeries and they start vomiting and it's that green, nasty bile kind of stuff, then your NG tube is not working effectively. If that NG tube becomes dislodged, as the nurse caring for this patient post-operatively, we are not going to replace it. We're going to call the physician because if they've had this surgery and they have all of these sutures in here, we do not run a risk doing anything to those sutures. They usually start them with clear liquids afterward, start slow, make sure they tolerate it, and then patient safety. So your ultimate goal for any of the bariatric surgeries, especially the ones where they're cutting, is you want to prevent any leaks, and you want to prevent any stressors from occurring. So if you have a patient with nausea, you want to try to get that nausea under control because you don't want them vomiting because it's going to put extra pressure on those sutures and then potentially you'll end up with a leak there. So you're going to monitor their oxygen level, the compression stockings. Some of these patients will be on anticoagulants afterwards, so some heparin therapy. But again, your first and foremost goal with these is to prevent the leakage from the surgery site. And so however you can do that, whether it's the nausea, whether they have an NG tube, so anything you can do to try to help prevent that. So some other things that you'll look for, usually after that first 24 hours, they'll want to get them up and about. So they usually have the urinary catheter for the first about 24 hours after surgery. so out of bed as soon as they can. Some may be able to do that sooner than others. And then turning every 2 hours. So your skincare. So a lot of these are going to be your normal post-op interventions that you would do with almost any patient. It'll be important to work with the dietitian or nutritionist to see what kind of fluids and nutrition they need. And in order to get in their calorie counts and everything that they're going to need, because that intake is going to be much, much smaller. So how do they get in everything that they're going to need to maintain? And then you'll monitor for signs and symptoms of dumping syndrome. So that would be the malabsorption. So if it's kind of just going in and going right through and it's pretty liquidy coming out, then and frequent, that would be your dumping syndrome. And so it's just coming in, but then it's not absorbing anything. So then to evaluate that, did you meet your outcomes? Have they been able to meet their kind of goals with nutritional intake? And then hopefully no infections and no complications after surgery. And then some nursing diagnosis that can be used just in general with obesity. And then you'll also want to look at, quality of life. You have some patients, we've all seen different TV shows, with, gosh, I can't even think of like Biggest Loser, or even some of those with, patients that just kind of become those hoarders that just don't even want to go out. They kind of just get so large that they can't even get up to do very much for themselves. It's just kind of the bare minimum. And so some of them become very isolated, depressed, their self-esteem. So looking at all of these, you'll have those extreme cases, but then you'll also have, milder cases. And so how from these aspects can you help support them too? So just a quick recap, because I think we're about done with this one. So it's a lifelong, usually obesity is a lifelong challenge for many. So healthy habits, healthy teachings, and then appropriate diet and exercise plans for them as well. So what questions? I knew we'd be able to cover this one. It wouldn't take quite as long.
Just a question back to when you were talking about the NG tube. You were talking really fast. So
Sorry.
That's okay. I have the part when you said that if the patient's vomiting a lot of green stuff, then that means the NG tube is not placed correctly. What else did you say? If it become dislodged, we wouldn't replace it, right? The physician, was that what you said?
Right. If you suspect that it's not in the right place, I would call a physician before I did anything to it. Yeah, that's what I would do. If you have that patient that has that NG tube, a lot of practices now are going to where they're not using it. But if they do have the NG tube in, and they're either vomiting, something's not right, it's not producing, it's not putting out, they're having a lot of stomach pain, then I would call the surgeon to see what they want to do with it, because they may want to come look at the patient. They may be okay for you to take it out, but before I would take it out, I would definitely be calling that physician. And the important, I would not replace, I definitely wouldn't replace one with all of those sutures in there, unless that physician wants you to. So I would wait and speak to that physician first. What other questions? A lot of this one is, for obesity, a lot of besides the actual definition of the obesity and morbid obesity and of being overweight, and then probably a few other things, I feel like a lot of this you've probably heard before because you've heard it in conjunction with other lectures. Like you've probably heard some discussion about, I'm trying to think of what other topics you guys have had, but you've probably heard some discussion about overweight patients because that's how they end up with some of the respiratory problems or some of the heart problems. And so this one just kind of puts it all in one place as a summary, basically on obesity. So when you're studying for your tests for me, I would focus first on your diabetes, then thyroid, then obesity last, kind of the order that we went in with teaching, and focus that way. What other questions does anybody have?
Will you post the blueprint today, or will it be later this week?
I will get that posted. I guess I haven't posted it for you guys. I'm teaching another class too, and I think I posted it for that one, so I'll get that posted.
Okay, thank you.
Mm-hmm.
I have one more question, Ms. King.
Sure.
So for the hormones, I know you want us to know if it decreases or stimulates appetite, but did you say you wanted us to know the individual ones just if they decrease or stimulate? Is that all you want us to know on them and be able to recognize it?
Pretty much. That way you can recognize those names if you were to see those. Then those would be great ones to. I could see like an NCLEX question in the future. That those would be a great one to throw in. Like even if a question about a cardiac patient, and maybe they're taking something that impacts those, and so then that would be your one clue to know, are they overweight or not. So it just is another factor of that, the whole patient.
Okay, thank you.
Mm-hmm. What other questions?
Ms. King,
Yes.
the worksheets that you posted online, do we have to turn those in, or we just do those on our own?
Nope, they're just for you to have to hopefully be able to apply a little bit more and gain some more insights and information.
Okay, thank you.
Mm-hmm. Focus more, I would focus more on the ones on slide 4. You would want, but like I said, for later, for NCLEX purposes or anything, you're going to want to study all of them, but I would focus more on slide 4. Any other questions? It's not garbage day today, so I don't have the dogs barking in the background.
Okay. So I know someone asked about the NG tube and if there was stuff other than gastric stuff coming out, what you would do. And you said you would want to call the physician. Like, what would be the course of treatment other than removing it or leaving it for them? Would they also want to get like a KUB, a chest X-ray or something to just confirm that it's actually out, if it is out?
So they could, I mean, they could do an x-ray. You could also listen. So, I mean, with that, you could listen and see if you get the air and if it's in the right place. So I would try to listen with air first before even calling the physician. That way when you're making that call to the physician, you can say, here's my assessment and here's what I've looked at. You know, I'm not hearing the air bolus, or I am hearing the air bolus. So either it's patent because I can hear the air bolus, or it's not patent because I can't get the air to go through. So that's just going to gain you more information in your assessment. And then if certainly the physician could order an x-ray, depending on what's going on. So I guess the piece that I really want to, since they did surgery on that site, you want to, and it's down in the stomach and there's sutures down there. The piece that I want to enforce is you don't want to do anything that's going to mess up those sutures. So I'm personally am not going to pull anything out or put anything in there until after I do a great assessment and I call the physician. And then whatever the physician says from there, he may say, okay, if, you know, to take it out, certainly I'd be okay to take it out. But most surgeons at that point are not going to want you to put anything in. They're going to want to put it in if they put it back in, because they don't want to mess up the surgery site. Not that as nurses you can't put it in. It's more protecting that surgical site. Does that make sense?
Yeah, thank you.
Okay. Because normally you put that down with no problem. It goes in, and if it rubs along the wall as it goes in, it's okay. But if it rubs along the wall in these patients, you're going to have sutures that it could be coming in contact with. So you don't want to mess up those sutures. Great questions. What else? Anything with diabetes or thyroid that you guys have as well? All right, well, I know it's a lot of information, so as you're studying, if a question comes up, feel free to send me a text, send me an email, and I will get back to you.
I have a quick question about thyroid. Do we need to know the ranges for T3, T4, TSH, or just whether or not they increase or decrease for hyper and hypothyroidism?
For any lab, I'd want to know the ranges too. Because if I give you a number, you're going to want to know, what does that number mean?
Okay, thanks.
Mm-hmm. Any other questions? All right, well, then I think I will let you guys get off here and you can have some extra time to study or use some of your other resources as well. So if you have questions as you're looking at it, just let me know and you can call me or talk to me, whatever. I'll get back to you as soon as I can.
All right. Thank you.
All right. Y'all have a good afternoon.
You too. Bye-bye.